pneumonia, and pulmonary embolus. Next slide. And the question was, is there an inhaled corticosteroid dose effect on the risk for these adverse events? Next slide. So the direct answer might come through randomized clinical trials or observational trials. And what they did was do an observational trial for medical records to try to effectively answer this question. Next slide. This slide shows their data. And these are patients with asthma who were recently started on inhaled corticosteroids. And they looked at MACE, which was major adverse events with cardiovascular systems, arrhythmia, pulmonary emboli, pneumonia. And then they also looked at control diseases, such as abdominal pain, cellulitis, urinary tract infection, and fracture in relationship to the dose of inhaled corticosteroid. At low dose, which is less than 200 micrograms per day, there is no increased risk. Next slide. Both in the diseases of interest and also in the other diseases. In the medium dose, which is 200 to 600 micrograms per day, next slide, we find that the data changes on this forest plot that were shifted over to the right, in which there is an increased risk for cardiac disease, pulmonary emboli, pneumonia, but there is not a risk for these other non-associated diseases. And finally, at high doses, greater than 600 mics per day, the risks are even greater. Next slide. This slide looks at the dose relationship and time of onset to these adverse effects. And if we look only at MACE, which is the cardiac diseases, we can see that once you start to exceed 200 micrograms per day, the risk goes up. And we also find that this is occurring relatively quickly. So although inhaled corticosteroids are highly efficacious in asthma, can control symptoms, can improve lung functions, we need to realize that there's an optimal therapeutic dose, and it's around 250 micrograms per zone per day. And exceeding this can be associated with significant adverse effects. So our corticosteroid stewardship really needs to not only consider systemic corticosteroids, but also high doses of inhaled corticosteroids. Next slide, please.
Yeah, Professor, just about the previous slide, for how long, more or less, was this dose given? Do you know?
We watched them over a year period of time. And after about 3 to 4 months, they could begin to see the increased risk for these side effects occurring. Granted, these risks are relatively infrequent, but they do occur, and this was just an observation over a year period of time. The other reassuring aspect of their study, Esri, was the fact that if they reduced the dose or stopped the dose, the risk for these adverse effects went back to baseline. So these risks are not necessarily, at least with inhaled corticosteroids, permanent, but can be minimized by either reducing the dose or stopping them when they are no longer needed.
Yeah. No, and I don't know if we could go back 2 slides further, because I think it was very interesting what you showed there, a bit more further back, when we had the rock curves. One further back? Yeah, no, back. It was still before the Bloom study. This one. If you see the graph on the left hand, now you can really see that the dose effect goes already up only in the green part for the efficacy, for the improvement in lung function, for improvement in FEV, for improvement in peak flow, the reduce and rescue medication, etc. Now all the solid lines are completely to the left. So there is a very clear dose response, but only in this very low dose group. Note it goes up to 250 microgram daily for fluticasone, if I understood correct. But the dose effect for the bad things, which are in the interrupted lines, these already start at the green part, but they just continue on and on and on to go higher and higher, more and more that we go in higher and higher doses, although the gain is very minimal. I think this is a very interesting curve you showed us here, Prof. Yeah, thank you. Now, if you now could go back to the slides, the last 2 slides on this chapter that I would like to, yeah, one more back. Yeah, it's just to stress again, because I was asked to be speaker for a thing with asthma, and then I got this slide about the adverse events with oral corticosteroids, and then the slide said 2 or more courses of short courses of corticosteroids, of oral corticosteroids a year. And I would like to very much stress what you already in your presentation told us as well. This is not in a year, this is in a lifetime. So already when we give more than 4 courses, short courses for acute asthma in a lifetime, that will add up to more or less 1 gram. This already is the yellow zone. This already is the zone where there is a problem signal visible. If we go over 4 courses in a lifetime, then we are in the orange zone with really a higher statistically significant frequency of fractures, of cardiovascular events, etc., etc. So if you go for the next slide, here I just put this with some drawings. Now, if you see, so for 2 or more courses, then we already go over the 500 microgram where there is milligram where there's no problem. We go into the in-between zone where there's already a signal for problems. And this can also be met if we only give low dose maintenance corticosteroid 5 milligrams a day for 3 to 6 months. Now, in severe asthma, it's easy that we just give this low dose thinking this is more or less a physiological dose. No, if we do this for over 6 months in a lifetime, then we already have this higher fractures, etc., etc. So it's really important that we try to lower the frequency of using systemic corticosteroids. And this already starts from the pediatric age onwards. Yes, please. Now for the next slide. So that brings us to the 4th topic. Now the lessons that we've learned from Eureka birth cohorts and children who develop persistent airflow obstruction. Please, Prof. Besse, could you tell us about this Eureka birth cohort of which you were very active part of the investigational team?
Well, thank you. This is the Eureka, this environmental and childhood asthma birth cohort. And this was begun approximately 20 years ago. And we recruited 800 children at birth into this cohort and followed them over the next almost 20-year period of time, beginning at birth, looking for factors that could affect their eventual development of asthma. These children were born to families which their mothers predominantly had high risk for allergic diseases and asthma. And we were interested in when did asthma begin, what were some of the characteristics, and what were some of the emergence of characteristics that we could find with more severe disease. The idea is to get clues to understand the trajectory of the asthma process over time, and to get an idea of when and with what we might be able to intervene to prevent the progression of asthma into more severe diseases. So again, at birth, we measured cytokines, we looked at their exposure with respiratory infections, the development of allergies. At 3 years of age, we looked at allergic sensitization, and they had recurrent wheezing, but we did not call them that indicate that they had asthma. And by 7 years of age, we had a number of very strict criteria for the development of asthma. And at this time, we were interested in what were the characteristics or phenotypes associated with those children who had asthma. And then when they became mid-age teenagers, 14 to 16 years of age, we were interested in the progression of this disease. So again, this is the birth cohort, about 800 children. And I want to go over with you some of the characteristic features of the various phenotypes or types of asthma or wheezing events that occurred in these children. Next slide. Next slide. So in this publication 4 years ago, the objective was to identify the specific respiratory phenotype and health disease in eureka and its association with early life exposures, both allergic and non-allergic, and also looking at the molecular patterns, that is, the genes that are expressed, which were underlying the eventual expression of the clinical disease. And we're looking at 10 years of age right now. Next slide. We had 5 characteristic phenotypes. But what I want you to look at is in the upper left-hand corner, children had any wheezing. As you can see by the green line, some children wheezed early in life, and as they got older, the wheezing episodes declined. But in the sort of red color, the wheezing began early in life and it continued. If you look at the number of wheezing episodes, or what would be almost like exacerbations, it's those children indicated by the red line that are most likely to be having these events. And on the lower left-hand side, we have the FEV1, forced vital capacity. And what you are seeing there is those children who have persistent wheezing, more frequent wheezing events, they have, beginning at around age 5, a decline in their lung function, and it is progressively worsening every year up to 10 years of age when we looked at the data. So what we see is frequent wheezing in some children can begin early in life, it can be persistent, it can increase in severity, and when this occurs, it's associated with a loss of lung function in these children. Next slide. This slide sort of looks at the association over the first 10 years of life in these children. And what we're interested in is those children who appear on the right-hand side of the slide. These are the children that have high wheezing, they're highly allergic, and they have low lung function. And there are 2 molecular features that are associated with the expression of the disease. The first is type 2 modules. That would be the eosinophils and the allergic aspects. And the second one that is very important is an overexpression of the gene MUC5AC, which is the gene responsible for overproduction of mucus. So in some children, beginning early in life, again, exposure to, house dust and also mold is a risk factor. They clinically are characterized by high wheezing episodes, they're highly allergic, and they have low lung function. These are the children that we need to be very alert to in our practice. We have to watch them very closely and have to consider these are the group of children who are going to have the greatest disease burden from their asthma and the greatest risk for asthma exacerbations. And what their molecular characteristics of their disease is type 2 inflammation characterized by eosinophils, an increase in exhaled nitric oxide, increased expression of IgE, and then in association with loss of lung function is the increase in this mucus, hypermucus production gene pattern. So again, looking at a birth cohort over a 10-year period of time, we can begin to pick out things clinically. Heavy wheezing or high wheezing episodes, highly allergic, is associated with loss in lung function. And we know the molecular basis which is leading to their disease, primary of which is type 2 inflammation, and then coming later on is overexpression of hypermucus secretion. Next slide, please.
Yes, that was really very interesting now, since so early on that we already can clearly detect this different group who just doesn't do it right, who just from very early age already is losing lung function. And yeah, the mucus plugging, I think, is also a very interesting concept that lately has become more to our knowledge, that the importance of it as well. And I didn't know, I wasn't aware that there was even a special gene that makes somebody more susceptible to do mucus plugging. Thank you very much, Prof. Bosse. I would like to show here just some 2 or 3 slides about our Mexican part of the ISAR, now the International Severe Asthma Registry. For now, the ISAR has been only registering adults. So the data I'm going to show you about ISAR are from adults. But if you could give a click more, please. We can see that IRA is now really already in almost 30 countries, and we have practically 35,000 severe asthma patients in the registry. This is an enormous quantity, and it makes us, it gives us the possibility, the opportunity to really analyze subgroups and compare different characteristics among patients and among trajectories. In Mexico, we are really happy, and if you give me one more click, sure, that's me there with David Price. We are very happy if you give one more click that in Mexico, we now already have almost 700 patients in this registry. And I really would like to thank, if you give me one more click, one more, sorry, it goes again there. There you go. I really like to thank now all the different sites in Mexico, the colleagues that are putting their free time into this to upload data of the patients, and it's really very needy that this has to be done. If something is not correct, we get the red light back from the central office in Singapore, and we have to go back to the data and adjust and correct them. So this is really quite a lot of work in the free hours of my colleagues, and really I would like to hear openly thank you once again. But I think it's really worthwhile if you give me the next slide, because we can now really start to see this pattern of Mexican severe asthma patients, which is a little bit different from the global patients we've been seeing. So these are the data of allergic comorbidities of the global ISAR cohort. And if you give me a next slide, please, then you can see here that on the left-hand side, the Mexican patients are more allergic. Now they have a higher, and all those are statistically significant. Sorry, I didn't put a piece there, but all of them are statistically significant, even the chronic rhinosinusitis. There's more atopic dermatitis, more polyps, more chronic rhinosinusitis, and much more allergic rhinitis in our Mexican group of severe asthma patients. On the other hand side, however, on the right hand side, you can see osteoporosis, diabetes, anxiety, depression, and obesity, where you can, if we get more, next slide, please, a lower frequency, fortunately, of these non-allergic comorbidities in our Mexican severe asthma patients, with the exception of sheer obesity, where our country at world level, I think, #2 with obesity. So yes, there we are still more frequent in obesity in comparison to the global ISAR data. Now, if you go to the next slide, these are not ISAR data. These are very preliminary data. Actually, they're about to be submitted for publication. These are the data from our colleague, Dr. Sarai Cerda, who works in Sedena, now in the military hospital, together with her colleagues there, Nidia being one of the strong supporters also as well. They have uploaded children into the ISAR registry, although this is not officially recognized as a group that should be in ISAR, but we use the ISAR platform. And now we can see here the data of their children, baseline data. You can see here that the mean age is 14 years, but that there also is a group of 11 children of these 60 children that are below 11, no, below 12, and the start age of their asthma was around 5 years for the whole group, and around 3 years, really quite young, for the younger children. Then there's a predominance of female in the whole group, but in the younger children, there's a predominance of masculine patients. And if we look here at allergic comorbidities, we also see a very high frequency of these allergic comorbidities, a little bit lower than in the total group that we saw with the ISAR, but many of their children are allergic as well. And then a little bit lower, you can see on which biologic they were put. It's almost omalizumab a third, dupilumab a third, and mepolizumab, it's only a few of them, because only recently we have now the official indication from mepolizumab that it can be prescribed from 6 years onwards. There's a special dose for the 6 to 11-year kids. It's 40 milligrams, and there's a special syringe to be used, but we will speak about this a little bit later on in our webinar. Almost all of them, 91%, are on allergen immunotherapy, because if you go a little bit on the last part of this slide, you can see that the vast majority have allergic sensitizations, and many of them, 80% in the whole cohort, have more than 4 allergic sensitizations. So they're highly allergic, as Dr. Bilbisi already showed us in his very first slides about severe asthma in children. Now, the next slide shows a little bit more about the severity of their asthma at baseline. We also have the 1-year follow-up data, but I won't show them here because this is going to be in the publication and they will be on slides of Professor Sarai. I don't want to show all her data here because this is really her data. So the mean number of acute asthma attacks was almost 2.5 per year. No children received systemic maintenance corticosteroids. ACT was low, and it was around 15 for the younger and the older children. You can see already a reduction, quite clear reduction in the lung function with FEV1 of 67% as a mean, and they were over 800 micrograms a day budesonide or budesonide equivalent. So really, even the small children, you can see in the second column, 750 micrograms a day of inhaled corticosteroid. If we understand the data well that Prof. Bassett just showed us, we are now really already on the top of the dosing curve. We might be over the best dose in these kids already at a risk for having systemic adverse events of these high doses of corticosteroids. And then you can see on the lower part here, the biomarkers all strongly skewed to T2 biomarkers with high FeNO, high eosinophil counts, and also high IgE for almost all the children. So these are the baseline data of our Mexican severe asthma children as seen in Sedena. Thank you very much again for Dr. Serra, who gave me official authorization of showing her data. Next slide, please. So this brings us to what could be the solution. Now, if we have already this quite clear group of children that goes on to have severe asthma and already showing this decline in lung function way before they arrive at 10 years of age, well, what could be done earlier on to try to avoid this? And I think here the MUPPET trials are very interesting, done with mepolizumab. Prof. Bussi, please explain us.
Thank you. And again, I think the introduction showing the risk that you've seen in the children in Mexico as far as disease severity and how important exacerbations are to causing the burden of the disease, and also that is found in type 2 disease. It lends itself very nicely to what I'm going to be talking about. And this is our study, which was trying to find out if we could get some insight into the transcriptomic networks. In other words, what are the genes that are associated with exacerbations that occur with viral respiratory infections and also with non-viral respiratory infections. So we have an idea, if we're intervening with biologics, where will these biologics be most effective? So the objective of this study, which was published now 6 years ago, was to determine the mechanisms by which a viral respiratory infection led to an exacerbation, because we know that not all colds lead to exacerbations. So it's not clear that every time a child gets a respiratory infection, that's going to have an exacerbation. But if we could have an idea of what characteristics are arising when they get a cold and it leads to a to a asthma exacerbation, I think we will have a better idea of how to more effectively treat these individuals and prevent their exacerbations from occurring. Next slide. So here's the design that we did. We recruited over 100 children, got baseline data, and these were all children who had a history of an exacerbation in their asthma. Next. So after this, we prepared them to say, if you get a respiratory infection on your cell phone, contact us immediately and see us, and we will characterize your exacerbation, get sampling from the upper airway, and then find out what happens over the next period of time. Next slide. So again, at 3 days is the onset of their cold, and 4 to 6 days later is really after the onset of cold symptoms. And what we're interested in, what are the exacerbations as indicated by the red circle, and non-exacerbations that occur with a respiratory infection. So we wanted to define these two. We wanted this information. So if we intervened with a biologic, as I will show you in the next slide with mepolizumab, why would we expect that treatment to be effective? We found that we had almost 200 exacerbations. 150 were associated with cold symptoms, and 47 occurred within about 10 days of these reactions. As you can see, only 1/3 of the respiratory infections actually led to an exacerbation. So therefore, treating every child with a cold, someone with preventative systemic corticosteroids, may not be a highly effective way of handling these diseases. And I think all of us have used this approach in the past, and I think it's time we sort of reevaluated what we're doing. So here's the setup. Baseline studies done, they get a cold, we bring them in, get samples, and then at the end of about a week to week and a half, determine whether or not they had an exacerbation. Next slide. So what I'm summarizing is in a cartoon fashion as to what is happening when, next slide, when they get a viral respiratory infection. So if they get a virus, there's genes that are activated, which activate a pathway called SMAD3. Next slide. In addition to that, another major activation occurs with epithelial cells generating IL-33 and turning on this eosinophil processes. Next slide. When this progresses, although children with asthma have low levels of interferon to begin with, and this makes them no doubt susceptible to getting a viral respiratory infection. But once the viral respiratory infection starts, interferons are produced in larger concentrations, and they're no doubt produced to try to reduce the severity of the viral respiratory infection. And then next slide, we see that this, if it progresses to an asthma exacerbation, we get increased mucus formation. We're starting to lay down matrix proteins, which could cause the remodeling in the airway, and eosinophils are associated with this. So type 2 inflammation, when it leads to leads to an asthma exacerbation, is both a risk factor and it is also activated when a viral respiratory infection progresses to an asthma exacerbation. So this is type 2 inflammation, not only a marker for being at risk for an exacerbation, but also participating in the exacerbation process. Next slide. If in contrast, next, if there's a non-viral trigger, we get a very different pattern. Again, we're not necessarily getting eosinophils early on. We are getting other factors, some of which are the kallikreins or other factors, next slide, which become generated and then lead to the asthma exacerbation. And eosinophils, if they do play a role later on. So not every exacerbation is going to be type 2 in characteristics, and this becomes very important when we're interpreting the effectiveness of an intervention with a biologic. So from these studies, we found that type 2 inflammation is a risk factor. It is activated when a viral respiratory infection leads to an asthma exacerbation, and therefore something that interferes with eosinophil participation during an asthma exacerbation should be an effective form of treatment. Next slide.
Yeah, this surely leads us directly to mepolizumab, no, as one of the strong anti-interleukin-5 type 2 inflammation, anti-type 2 inflammation biologics. Go on, Bill. I won't interrupt here further.
So again, this was the first study published in the New England Journal of Medicine of Leicester. And again, which Holden reported the effect of mepolizumab on exacerbations in adults who had refractory eosinophilic asthma. So they looked at peripheral blood eosinophils and sputum eosinophils and treated some with mepolizumab and some with placebo. And they looked at what effect this could have if these patients had persistent airway eosinophilia despite aggressive treatment of their disease. Next slide. So this shows the characteristics. Small study, approximately 50 plus people enrolled. They were about 50 years of age. They had a history of 5 exacerbations. Their FEV1 was mildly compromised. They were on large doses of inhaled corticosteroids, and about 50% of them were on regular doses of systemic corticosteroids. And despite that, they had high eosinophil counts in their sputum and over 300 cells, eosinophils per microliter in their peripheral circulation. Next slide. And here are their results. The mepolizumab is the orange line, and this is following over a year, and versus placebo. Again, with guideline type 5, step 5 treatment, there's a 50% reduction if you're treating these individuals with mepolizumab, which interferes with eosinophil formation and persistence. And this is what was seen later on in many of the studies with asthma. There was consistently a 50% reduction in asthma exacerbations with mepolizumab. Next slide.
Yeah, that was the early data, and I didn't realize 2009. This is over 15 years back now already. Amazing, no?
It is amazing. It is amazing, and again, it's held up to the time test that we've given it. But again, now we've moved into Muppets 2, which is actually looking at intervening, and this was published with Dan Jackson as the principal author 3 years ago. It's mepolizumab for children living in inner city asthma who have eosinophilic asthma, are exacerbation prone, and we compared mepolizumab to placebo in these children. Next slide. So here's the design. These children had a history of asthma exacerbations. They had eosinophil counts over 150 cells per microliter. They had a 4-week run-in, and they were randomized, either continuing on current guideline-directed care or given mepolizumab, the dose depending upon their weight. And we watched them and we followed them over a year period of time to look at the primary outcome, which was the rate of asthma exacerbations. We also obtained transcriptomics with nasal washes, and we'll come back to this in a while, which I think gave us some new insight into what can be going on as far as controlling the frequency of asthma exacerbations with biologics. Next slide. These are some of the characteristics. Placebo-treated, mepolizumab-treated, some compromise in lung function, highly allergic, about 90+% of them were allergic. And again, their eosinophil counts were around 400 to 450 cells per microliter. No question that they had eosinophilia. Their IgE was elevated, and virtually 2/3 of them were on high doses of inhaled corticosteroids. And in the year preceding, they had about 2.7 to 2.8 exacerbations of asthma or burst of prednisone. Next slide.
I think this is very interesting because it's quite similar as the profile we had for the Mexican children. Notice the asthma children.
Very much so, Desiree. When you were going over that, I said, these are replicates. They're replicates.
Absolutely, absolutely.
Right.
And maybe to stress here that there was also quite I think a high group of Hispanic children in the Muppets too.
Yes, again, they tend to be Dominican Hispanic rather than necessarily Mexican Hispanic from New York and Boston. But again, they have severe disease. But again, I think so much of the advantage of your ISAR participation is worldwide study, we can generalize to many populations. And again, this is somewhat of a unique population of very high-risk children, but very similar to what you saw in Mexico. Next slide.
Thank you.
And again, as we talked about the positive skin test, next slide, high eosinophils, next slide, and the high treatment level. Next slide. Here, we also looked at the eosinophil count in box A, which is in the peripheral circulation. Placebo stayed stable at about 450 throughout the study. On mepolizumab, as expected, it dropped very low as anticipated. We also looked at nasal eosinophils as a marker of airway eosinophils, and here the compromises were not as profound as we saw in circulation, and this has been noted in other studies. And I think it becomes important to realize that the airway may be somewhat resistant to loss of the eosinophils in these individuals. Next slide.
Yeah.
This is the primary outcome. There was about a 27% drop in the frequency of exacerbations with mepolizumab. And this was certainly less than what we had anticipated from the experience that was seen in the adults. Next slide. If we look at the seasonal pattern, which is so important, children have problems in September and October when they go back to school. And again, as you can see here in the placebo is indicated by the red, the frequency of exacerbations increases. And when they're on mepolizumab, they still have exacerbations, but the frequency is significantly reduced by about 36% rather than 27%. Next slide. So what we were also interested in was what were the underlying mechanisms that might explain the phenomenon that we saw in these children. Next slide. So this is a complicated slide, and I'm just going to go over a few points very briefly. We looked at genes that are associated with type 2 inflammation, eicosanoid metabolism, and otherwise. And the red bar indicates what happened to the children with an exacerbation when they were on standard treatment. As you can see, it increased. So type 2 inflammation increased in their exacerbation time, whereas indicated by the blue bar, this did not happen when they were on mepolizumab. So mepolizumab interfered with activation of type 2 inflammation. However, and very surprising to us was that in the presence of mepolizumab, there was not the blockage of mucus secretion. The epithelial function was not changed. So again, I think we understand that children may be different than adults, and this may be why we did not see the high level of anticipated prevention of exacerbations. And again, by understanding the differences in the genes that are activated, we might have a better understanding of how these biologics are working in high-risk situations. Next slide.
Yeah, that leads us, I think, to the final topic we would like to speak to you about tonight. And surely, I think nowadays the talk on severe asthma is not complete if we not speak about the very fashionable term of remission. Now, not confusing remission with cure. Now, remission here we're speaking about zero symptoms, zero of many things, but on treatment. Bill.
Again, as you'd indicated, Desiree, we've become very interested, I think very appropriately, in remission. It's not a cure, but it means that the disease is really quiescent. And again, if we look at the span of what's happened over the last 40 years, we see, first of all, it was relief of symptoms with bronchodilators, then control of disease control with the use of inhaled corticosteroids and long-acting beta agonists. And now we've begun to move into trying to get more total control, trying to not only prevent exacerbations, reduce symptoms, and also stabilize lung function. And again, we're monitoring this, and we now have available the biologics which can allow us to do this. As a consequence of the effects of biologics, which have been quite dramatic on asthma, again, we've begun to rethink what can be the outcome that is associated with treatment. And next slide, please. And this is a proposal that we came forward with a number of years ago now. And what are some of the clinical remission characteristics while on treatment that we would be interested in achieving. It would suggest that we really have better control of asthma. An absence of symptoms, an optimization or stabilization of lung function, and again, also preventing the need for systemic corticosteroids for exacerbations. Therefore, I think the two big things we're very interested in is preventing exacerbations and preventing, therefore, the need for systemic corticosteroids. Next slide. Well, how effective is this? Again, this was a publication by Ian Pavord about 2 years ago, looking at the READIES trial. And this is looking at the effect of mepolizumab in people with severe eosinophilic asthma. And did they not only have safety with the treatment, but also how might it have affected a more composite view of asthma control as reflected by remission. Next slide. So 12 months of treatment with mepolizumab and looking at the effects on criteria for remission, criteria that I just presented on the previous slide. Next slide. And they looked at 3 outcomes: exacerbation-free, oral corticosteroids free, and control-free, as indicated by an ACT score of 20 or greater. Next slide. And if you looked at 4 outcomes, this is looking at some other modification, looking at lung function going up to 80% or better, post-bronchodilator. Next slide. I'm going to just look at the 3 outcomes. If we look at the left-hand side, we see that only 8 out of 260 patients met, criteria, for remission. And it was found, or I should say, it just was very infrequent. Again, 6% of them might have met the exacerbation-free. Some of them might have met the oral corticosteroid free, and their symptom scores was only in 14%. However, and again, 31% of them met none of the criteria. Whereas if they went on mepolizumab, as you can see, now only 8% of them did not meet this criteria. And you see that 52% were exacerbation-free, 82% were free of the need for systemic corticosteroids, and 73 were well controlled. It's not perfect. It's not been perfect with any biologics, but looking at remission gives one a view of the composite outcome of how our treatment is affecting asthma. And again, I think that this has become an important step going forward to better understand how we can more effectively control asthma and relieve the burden of the disease for these individuals. And this is especially true in children, so they can have a normal growing up period of time and normal experiences as a child. Next slide.
Yeah, thank you very much, Bill. That was, I think, a very complete overview, of these 8 different topics, one by one, leading us to the final conclusion of, how could we better reach remission, and particularly in children. Also showing us clearly that not all exacerbations can be avoided in children when we start anti-T2 therapy, because some of the exacerbations are not really T2 related. No, it's more also related to changes in epithelium, mucus plugging, etc., etc. So I think, these are very interesting insights, and surely we'll have to see kids being put on mepolizumab will follow up in the next 3-5 years. How does lung function evolve in them as compared with children just only put on inhaled corticosteroids? I don't know. I had we saw here in the chat one question of one of our colleagues, Ruth Serino, from Villahermosa, from the south. And this is about the cumulative dose of corticosteroids in a lifetime. She answers, does also the dosing that we put intra-articular in the joints, do those doses also add up to the total dose? Honestly, I don't know.
Nor do I, Desiree, but I do think that they are all adding up. And again, recently, at an appointment with one of the orthopedic individuals, and they were saying they are giving doses of corticosteroids for joints. And he said, we stop at 3. And he said, because if we go higher than that, we are putting you in risk for side effects. And I thought, okay, I think many of our specialties are beginning to realize that these corticosteroids, although highly efficacious, have side effects. And again, this was observed with the first uses of corticosteroids in rheumatoid arthritis, how rheumatoid arthritis disappeared with prednisone, but side effects occurred.
The buds were too high. Yeah.
Now, there are effective dosages, like every other medication, right dose for the right period of time.
Yeah, absolutely. Then there is another question here. How often do you encounter alternative diagnosis in poorly controlled pediatric patients who initially thought to have asthma, but that really is not asthma? Is this often?
Well, I'm going to let you comment as well as me, because you've had more experience with children. But again, I think one of the things that we worry about, of course, is vocal cord dysfunction, reflux esophagitis, also affecting the upper airway. They can also occur concomitantly with asthma. So I think we may be thinking about that. And again, there was a very important study done in Canada in which they called people in who'd been on asthma treatment. And they found that about 30% of the people who were treated by physicians didn't have asthma.
Yeah.
So I think, again, lung function tests are very important, understanding what the symptoms are. We need to always take a step back, particularly if patients aren't responding to treatment, and say, is this the disease? What's your experience in children?
Yeah, I think I very much agree with you. And that's also the same thing something we stress very much in the Mexican asthma guidelines. Now, particularly in the young children, 4 years down, if they are not responding to the therapy, probably it's because it's not asthma. So be very careful to go up and up and up in your corticosteroid doses when possibly the diagnosis is not the correct one, or there is a comorbidity that makes them uncontrolled. No, so yeah, I very much agree with you, Bill. Here another question is about, well, also do intranasal corticosteroids add up? Yes, sure. I think all corticosteroid that's been put into the body adds up to this total corticosteroid dose. And another anonymous colleague asks us here experience with other biologics, if this is similar as shown for mepolizumab in children.
Well, I think the experience in children, again, has been primarily with dupilumab, where they have seen, the effect. That is, I think, as far as blocking at about 50% of the exacerbations. And one of the interesting things in those studies have been 4 and 13 are acting through epithelium. And you wonder if, the epithelial becomes a different target. Whereas in adults, what we're seeing, dupilumab and mepolizumab and benralizumab, the anti-5s, are very similar. In children, we're having more limited experience at the present time. And I think biologics, have just been such a wonderful thing, but we really need to get a better idea in whom they're going to get the best effect from.
Yeah. I have one more question. We have one more question here from Hefsi Jimenez. That's about what has been the most challenging case you faced in managing severe pediatric asthma. Well, my case, I think, and this was before we had access for children to biologics, was and he, even when I was on the television, he was one of the patients they interviewed, because his major problem was his obesity. Together with his severe asthma, he was just getting so stressed out that he was eating more and more and more.
Wow.
And finally, it was almost impossible to control his obesity. And then surely asthma became got more and more out of control. And even so, he would play his soccer game, and then at half time he would just do his puffer, cough up, vomit all the phlegm, and continue the soccer game. this was really a case that hurt me very much, and I was not able to control him well, and it was in the pre-biologic era. So I tried not to again and again use systemic corticosteroids, but it was very difficult to not get him exacerbate time and again.
Right.
I think it's still one of my most difficult patients.
Well, I think the other area which has been very difficult from my perspective in the adults has been the T2 low.
Yeah.
We just don't know the character. We don't have biomarkers for this. We don't have an intervention, for this. And again, they are quite symptomatic. So this has been hard. And again, I think we also have to realize that the pattern of inflammation in asthma is fluid.
Yeah.
It shifts around, depending around what we're being involved in. And therefore, although we have all the reason to suspect that our intervention is going to work because they've had eosinophilia and exhaled nitric oxide elevations, it may not work because under different circumstances, what's causing their disease to be worse is non-T2 high. And so I think we need some stuff. But again, I think it's also very important for physicians and the public to realize asthma is a complicated disease.
Mm-hmm.
And this is why specialists really should be managing those with more severe disease.
No, and even, well, as her asthma guidelines tell us, asthma specialist is one. Severe asthma specialist is still another thing. And it's not just a bit more severe of the same thing of asthma. No, it's really quite much more complicated.
Very much so. Very much so.
I would like to recall here, I don't know if we have one slide, because I think we have to also give some credit to JSK, who is sponsoring this whole webinar tonight with us, to just recall the dosing of mepolizumab in children. I don't know, Alfonso, I think we have a slide there. Alfonso, no sé si tienes la diapositiva de la dosis de mepo. This is a very important slide. First, this one. Just to remind the audience now that there's a special dose for the children. 6 to 11 years is the 40 milligram dose. And it's a special syringe that comes, pre-filled syringe, that comes exactly with the dose. So this has to be given every 4 weeks, just as the normal 100 milligram dose. And this is now officially approved here in Mexico from 6 years and up. So I think just to make very clear the dosing for the children, and you can see here also in the diagram of the child that you can put it in different places. It can be put in the arms, in the belly, or in the muscles in the legs. And then, well, at once, if you want to go for the next slide, Alfonso. That is surely remind you of the Mexican asthma guidelines. Now we just published the update. It's already presented officially in Semica, and I hope to see you in 3 weeks in Compedia. We're again gonna bring quite a bunch of printed guidelines, and if not, here's the QR, so you can already have access to the whole content. And in the guideline comes a very clear chapter also on severe asthma. How can you better select now among the different biologics that we have now available for which kind of patient a certain biologic might fit in better or worse. And we have also a special diagram there for the children, for the pediatric severe asthma. So you can all find it in MIA 2.0. Thank you very much for this slide, Alfonso. Well, I think with this, we already went 10 minutes over time. I have one last question maybe here. There's something about probiotics. There's something about GERD. Okay, well, I picked this one about a repercussion positiva entre el control del flujo a mediano corto plazo. Okay, if you can control better reflux, gastroesophageal reflux, if this will also positively impact on the progress of severe asthma. Yeah, surely this is one of the comorbidities, Juan Carlos, and it can help us even to bring a patient from supposedly severe asthma back to moderate asthma, because he was exacerbating sometimes just because of reflux, not because of inflammation of the lungs. So yes, it is very important to always attend all comorbidities as best as possible. Well, this will end for us, I think, now this webinar. I will hand over now the comments to Dr. Macías Weinman. Ale.
Muchas gracias, profesor Bruce. Y deciré, la verdad que ha sido un webinar excelente. Hemos tenido una asistencia récord, no solamente de diferentes estados de México, sino así como también Centro y Sudamérica. Quedaron ahí un par de comentarios en el chat que no alcanzaron a entrar en la preguntas y respuestas, solamente haciendo énfasis en la necesidad de utilizar los estudios de función pulmonar y el estudio del feno también en edad pediátrica, lo cual, bueno, creo es importante. No sé si quieran hacer un último comentario acerca de esto.
Sí, yo creo que me encanta lo que. Oh, sorry, I'm switching to. I really like very much what our respiratory physician colleagues, when we work on the guideline, have told us so much. And one of the important things they always told me from the very beginning of MIA, even the GIMA, they said, well, okay, if you have a diabetes patient, you don't look at the face and you say, okay, I think you have a blood sugar of 150 today. No, you measure. So when you think there's asthma, measure. Do the spirometry pre and post bronchodilator, and nowadays do the pheno. No, and well, finally, I bought also pheno for my clinic, and my experience is that the children, even the small children, 4 years up, can already blow a pheno, even though sometimes they still not do spirometry. So I think there's very important tools to make much more clear, well, how important the inflammation or the lung function deterioration is. I don't know if you would like to add something more, Bill.
No, I just think when we have data to explain what's going on in the patient, we will do such a better job in treating them and understanding their disease. And I think taking advantage of information, particularly as the one comment made, measure the lung functions, measure the eosinophils, measure the pheno, you will do better for your patients, and your patients will do better as well.
Pues muchas gracias, ha sido un webinar excelente, muchísimas felicitaciones en el chat y bueno, despedimos a nuestros profesores, el doctor William Bussey y la doctora Desiree Arenas Lineman, y nuevamente los invitamos a vernos en un par de semanas en Puerto Vallarta del 9 al 12 de julio en nuestro 32º congreso, así como en el precongreso, que son los highlights, que serán híbridos. Pueden copiar el QR que viene en pantalla. También les vamos a poner en el chat la liga para que puedan inscribirse. Si no van a estar presenciales en Puerto Vallarta, pues nos pueden acompañar en línea, no tienen ningún costo. Nos daría mucho gusto saludarlos. Les recordamos que al final viene la encuesta que tienen que completar, el cuestionario, para que pueda llegarles su constancia. También en el chat va a aparecer la liga para que lo puedan completar. Y nuevamente muchas gracias a nuestros profesores y a ustedes por su asistencia y los esperamos en nuestro próximo webinar. Que tengan muy buena noche.
Thank you very much, Bill.
Bye.
Muchas gracias, Ale. Y gracias a
Nos
todos los
vemos
asistentes.
ahorita.
Thank you.
Bye.